that, sir, please stop share, sir. Stop share, please, sir.
No, I'm not able to
Sir,
understand.
sir, உங்களோட stop sharing பண்ண சொல்றாங்க.
Oh, stop. Okay.
Yes.
Go to slide.
Rahul, you're not audible.
Yes.
Please write it in the comment.
Ma'am, this is Swati from our team. We can start the session.
Okay, just giving the countdown now.
5, 4, 3, 2, 1. We can start.
Let's start.
Good afternoon, everyone. Today, we are very happy to have Dr. Janarthanan with us, and Sir will today help us understand the synergy of the molecules glimepiride, metformin, and sitagliptin together, and how it can be effectively used in the uncontrolled type 2 diabetes patients, in the uncontrolled infant type 2 diabetes patients. So I'll start with Sir's introduction for all of you. So Sir completed his MBBS from Government Stanley Medical College,
Advocate,
Chennai.
ma'am?
Yes. And his MD from non-interventional cardiology from Yerevan State Medical University, N1 University Hospital. So has a tremendous work experience with him, starting from he has worked in Bharti Raja Multi-Speciality Hospital, Chennai, where he was managing the cardiac outpatient department. He has also been an associate consultant in Hridaya Cardiac Emergency Care Center at Karnataka. He has also been a junior consultant in Thatgat Heart Care Center from May 2017 till April 2018. He has also been a consultant in Thatgat Polyclinic. He has also been an associate consultant in the Department of Cardiology at Narayana Hridaya. Sir has various accolades to his credit, like he's been certificated with basic echocardiographic course from MMM Hospital, Chennai. He has completed his post-graduation diploma in clinical endocrinology and diabetes from Royal College of Physicians 2019. He also has been certificated of completion in advanced ECG interpretation, participated in American Heart Association selected issues in hypertension in self-assessment program. Has also participated in evidence to experience symposia. Has also participated in ISACON, which is the 14th annual conference of Indian Society of Electrocardiology, and participated in CME on update of cardiology conducted by European CME. Sir, I would like to hand over the session to you.
Thank you. Thank you so much. Shall I share my screen? Is it visible? Hello?
No, sir. Now you can share the screen.
Yes.
Visible now? No?
No, sir.
Now?
No, sir, it's not visible.
Not visible. Just a moment. Just a minute.
Yes, sir.
I think it should be visible, isn't it?
Yes, sir.
Okay. Good evening, good afternoon, everyone. Today, we are going to see briefly about some synergetic effect of some three oral hyperglycemic agents. And so, to begin with, a case history of a gentleman of 52 years old with duration of diabetes of 4 years, and his present glycemic parameters with the fasting blood glucose of 144 milligram per deciliter and postprandial of 198 milligram per deciliter, and with HbA1c of 8.7 percentage, and also he is a known hypertensive. So being diabetic for 4 years with an HbA1c of 8.7 percentage, it is considered as very much uncontrolled glycemic control. And presently he is on glimepiride 3 mg and metformin 500 mg. So in this in this kind of setting, like what we will do basically, whether to increase the dose of existing combination drugs or to add on a new drug, so that we can achieve the glycemic target in this particular patient. So we'll see briefly. So, like either increasing dose of glimepiride, or do we have any other option in this particular clinical scenario? So this is not an uncommon problem. This kind of you know patient types we used to see in our everyday clinical practice. So it is not an uncommon problem. It is probably a common issue. And to start with, the prevalence of diabetes in India, according to this ICMR and in diabetes study, so almost around over 100 million people are diabetic, and more than 130 million people in India are diagnosed to be pre-diabetes. And apart from that, the prevalence of various other comorbid conditions are also very high. Out of which, when we see the obesity, generalized obesity and abdominal obesity, so the prevalence of generalized obesity is more than 250 million, and abdominal obesity is more than 350 million. So these set of patients, they are at high risk of developing diabetes in the near future. So as a whole, like the overall weighted prevalence of diabetes by OGTT was 11.4% according to this ICMR in-depth study. And out of these diagnosed diabetic patients, a vast number of patients there under suboptimal glycemic control with an average HbA1c of 8.5% and an average fasting blood glucose of 172 milligram per deciliter and an average ppg of 253 milligram per deciliter. So out of only 33.1% of this diabetic population who are diagnosed as an HbA1c of less than 7%. So almost a 67% of the people, they were not under targeted glycemic control. So that is a huge number. So this explains the gap in appropriate or early intervention and monitoring. Now, if we look into a study by UKPDS and also a great study, so where they observed like the type 2 diabetes is an progressive disease, and also the loss of control in continued therapy, like either it is with monotherapy or an add-on therapy. So there is a loss of control over a period of time. So definitely, like, this explains like increasing the dose of a particular agent might not be helpful throughout the course of the treatment. So maybe now and then the treatment has to be modified, or some add-on therapy has to be adjusted according to the particular or individual patient profile. So how do we deal with this problem? So this slide or this picture explains the different pathophysiological, pathophysiology of diabetes mellitus. We call it as omnious octet. So there are 8 pathophysiological entity which explains the diabetes mellitus. So there might be a decreased insulin secretion or increased glucagon secretion. So there might be decreased incretin effect with respect to the GI tract. There might be an increased lipolysis or increased glucose reabsorption from the kidneys, or there might be a decreased glucose uptake in the muscles. We'll call it as peripheral resistance. And centrally mediated there might be dysfunctional neurotransmitters, and finally increased hepatic glucose production in the liver. So these are all the eight pathophysiological disorder which might lead to the diabetes mellitus. So, and also there are the very each pathophysiological disorder has been addressed or affected by various oral hyperglycemic agents. For example, if we take the DPP-4 inhibitors, it can increase the insulin secretion, that is glucose mediated increase in insulin secretion, and thereby also it can also decrease the glucagon secretion. And with respect to incretin effect, it can increase the incretin effect, and it has some role in regulating the neurotransmitter with respect to diabetes control also. So likewise, like various oral hyperglycemic agents, affect the different pathophysiological disorder that leads to diabetes mellitus. So, as we told earlier, that is the earlier and appropriate intervention might improve the patient's chance of achieving the target glycemic control. So here, this picture, they compared the conventional stepwise treatment approach with the earlier and proactive interventional approach. What we see here is like it is an conventional stepwise approach, like when the patient is diagnosed with diabetes, initially advising with diet and exercise, then observing for a period of time, then initiating with a monotherapy, most probably with a metformin, and again observing for a period of time, then up-titrating the monotherapy. For example, if it is like initiated as a twice daily dose, that up-titrating it to thrice daily dose. Likewise, then if that doesn't work out, then going for an combination therapy, then observing for a period of time, then along with that, adding a basal insulin, and again going on for a month, multiple daily insulin. So this is what the conventional stepwise approach. So the drawback with this kind of approach is like the patient might not achieve the target glycemic control at the earliest. So thereby there might be the chance that patient might land up in diabetes related complications early in the life. For example, vascular complications early in life. So this, when compared with this this early and proactive interventional approach. So, initially, according to the patient glycemia, like whether if it is what is the HbA1c diagnosis, it is less than 7.5, more than 7.5, or it is more than 8, more than 9, accordingly, and depending upon the patient profile, it is a young patient or older patient above 80 years. So depending upon the thing, so some major bodies like they recommend initiation of a dual oral hyperglycemic agent, or if necessity, if there is a necessity, if there is a need, if the glycemia is very high, if the HbA1c is more than 9, and you may initiate with an triple drug combination at the diagnosis. Thereby, you can achieve the target glycemic control at the earliest, thereby preventing the complications related to diabetes. So this is an input from the American Diabetic Association and also American Society of Endocrinology. So wherein they told if the initial HbA1c is more than 7.5%, early combination therapy with two agents may be needed. And for those with an initial A1c of more than 9% or 1.5% above goal, then 2 or 3 anti-hyperglycemic agents should be initiated concomitantly. So they recommend a combination therapy at diagnosis if the HbA1c is more than 7.5%, and a triple drug can be added if the HbA1c is more than 9% to achieve the target glycemic control. And so what are all the advantages of this combination therapy when we see? So the approach, different this combination therapy approach, different pathophysiological disorders in type 2 diabetes, as we saw in the previous slides, that that different drugs may affect the different pathological disorder that leads to diabetes. So the approach different pathological disorders in type 2 diabetes, and it might prevent the progressive loss of beta cell function. So there we can expect some preservation of beta cell function with the combination therapy, and it might prevent or reduce the combination. For example, instead of regulating the sulfonylurea dose keeping the sulfonylurea at a low dose and adding on some other drugs along with that might reduce the side effect of serious side effects of hypoglycemia and also weight gain and other stuffs. So counter therapeutic and clinical inertia and improve the glycemic control. So synergetic effect, it is proven to improve the glycemic control and also improve adherence from the patient side. So when the pill burden is reduced, so instead of taking 2 or 3 medications when the patient is given a combination therapy containing 3 drugs in a single pill, so they will be very happy to take, and the adherence will be very good in terms of with respect to combination therapy. So synergetic activity between different OADs can improve the outcome multifold. So what is this new synergy on the horizon to tackle with this conundrum? So primarily in our practice, general practice, what will be our main concern or main consideration with respect to diabetes management is like to achieve the target glycemia with low risk of hypoglycemia, with very low risk of hypoglycemia. So achieving the target with low risk of hypoglycemia is the main consideration with respect to diabetes management, irrespective of the age. So what are all the risks? So when we take into the account the case history which we saw before, that gentleman who was already taking a glimepiride 3 milligram with metformin. So in that scenario, keep on increasing the glimepiride dose might have some effect on the beta cell function. There might be a progressive loss of beta cell volume and also beta cell dysfunction, and it might increase the risk of hypoglycemic events and also weight gain. So a study with glimepiride combination and DPP-4 metformin combination. So wherein the hypoglycemic events in the DPP-4 metformin arm is very low when compared with the glimepiride arm. So that explains, like, keep on increasing the sulfonylurea dose might put the patient at a higher risk of hypoglycemic events and also weight gain. And also we can expect a progressive beta cell dysfunction. So what are all the rationale of low dose glimepiride in combination with sitagliptin and metformin? So what we can able to expect with this kind of combination? So the prolonged activity of intact GLP-1 by DPP-4 inhibition is likely to both improve glucose-induced insulin secretion and to decrease glucagon levels, so resulting in maintenance of beta cell function. So provides a complementary mechanism for glucose-induced insulin secretion, leading to improved diabetes control. And also, sitagliptin is known to exhibit some synergism with metformin through several mechanisms. And metformin can reduce insulin resistance, and glimepiride can increase the insulin secretion through stimulation of pancreatic beta cells, thus addressing the multiple pathophysiological issues in type 2 diabetes. And also, sitagliptin, when added to the lower dose of glimepiride, has shown to improve glycemic control with no increased risk of hypoglycemia. That is more important. So, in addition of sitagliptin is expected to preserve the beta cell function as seen through the studies evaluating pro-insulin-insulin ratio. So it has many advantages from preventing hypoglycemic episodes and also preserving beta cell function or preserving the loss of beta cell volume and achieving the glycemic control and also synergetic effect between the molecules. So it all leads to achieve a very good target glycemic control with a very less episodes of side effects, for example, like hypoglycemia. So can we achieve a better glycemic control by decreasing the dose of glimepiride and adding a sitagliptin? For example, for taking as an example as the previous case history, wherein the patient was taking a glimepiride 3 milligram and with metformin 500 milligrams. So whether decreasing the dose of glimepiride in that particular patient and adding a sitagliptin, so would that be helpful in this kind of clinical scenario? We'll just see. With the phase 3 study of sitagliptin, glimepiride, and metformin fixed dose combination in India done by Sun Pharmaceuticals. It is a phase 3 trial. The objective of this trial is to assess the efficacy and safety of fixed dose combination of sitagliptin, metformin, and glimepiride in comparison to the co-administration of metformin and glimepiride in patients with type 2 diabetes. And the sample size is 392 subjects across India, and study duration is 30 weeks for test arm and 18 weeks for comparator arm. And the screening period, that is the prior to and the study start date, is 2 weeks, and the study treatment period is like 28 weeks. That is double blind, both with both the test and comparator arm for 16 weeks and open label test arm for 12 weeks. So this screening visit, it is a multi-center randomized comparative trial. It is double-blind, double-dummy phase 3 study. The screening visit, like patients were on a stable total daily dose of glimepiride 4 mg and metformin more than or equal to 1500 mg for at least 10 weeks. This is prior to the study start date. And the patients, they had an average HbA1c of more than 8 to less than or equal to 11%. So then the study after this the study start date, they compared they are divided into two groups, like test one and comparator arm. The test one, the patients were subject to take the glimepiride dose has been reduced to 1 mg, and the sitagliptin 50 mg was added to that, and along with metformin 1000 mg with matching placebo of comparator product. And the comparator arm, co-administration of metformin 1000 mg and glimepiride 2 mg with matching placebo of test one product. So here the glimepiride 4 mg, it is a step down approach, has been reduced to 1 mg, and add on sitagliptin and with metformin. And the patient has been followed up for a period of 16 weeks, and the assessment was done at the end of 16 weeks. And if the HbA1c remains more than 8% at week 16, then the patient enters into the tests 2 with the fixed dose combination of sitagliptin 50, metformin 1000, and glimepiride 2 mg. From 1 mg, it is slightly updated to 2 mg. So now the patients were on glimepiride 2 mg, metformin 1000 mg, and sitagliptin 50 mg twice daily dosage. So then the patients were followed up for a period of 28 weeks, and at the 28 weeks, what is the observation we'll see later. And the inclusion criteria for this study is like patients of either sex, aged between 18 to 65 years, and ready to give written consent to participate in this study. And as we saw before, the HbA1c of the patients involved in this study is more than or equal to 8 and less than or equal to 11%. And patients, along with diet and exercise control, additionally on a stable daily dose of glimepiride 4 mg and metformin more than 1500 mg for at least 10 weeks prior to the screening. And patients with BMI of less than 45 at the screening, and women of childbearing potential must have a negative UPT prior to study entry and agree to use highly effective methods of contraception to prevent pregnancy from study entry till the last dose of study medication. So the study endpoints, the primary endpoint is like mean change in HbA1c from baseline at the end of 16 weeks. And there are various other secondary endpoints like, mean change in HbA1c from baseline at the end of 28 weeks. And also like mean change in the fasting blood glucose and post-pandemic blood glucose at the end of weeks 12, 16, 24, and 28. And, number of, patients participating requiring hypoglycemic management, or number of patients requiring, reuse medication or any change in medication or any modification in the dosages. So all these has been put into the secondary endpoint, the secondary endpoint. So what are the results of this phase 3 clinical study done by Sun Pharma? Is like these are the baseline characteristics of the patients involved in the study. So in the test group and the comparator arm, so almost 102 male in the test group and 121 male in the comparator group were involved. And with female patients, like in the test group, it is 88, and in the comparator group, it is 81. And with respect to other parameters like age, height, weight, BMI, it is all almost similar parameters, like the baseline characteristics were comparable in both the treatment groups, both in the test group and the comparator group. There is not any much difference in the baseline characteristics. So when coming to the efficacy results, at the end of 16 weeks, in patients with an FDC like sitagliptin, metformin, and glimepiride, they have a superior HbA1c reduction at the end of 12 weeks and also at the end of 16 weeks. So when compared to the comparator arm. So when you can see at the end of 16 weeks with this FDC combination, like there is almost an 1.79% reduction in HbA1c when compared to 1.28 with the comparator arm, like with an metformin and glimepiride combination. So, and also if we compare the mean HB reduction, mean change in the HbA1c from the baseline at week 12, 16, 24, and 28, you can observe an sustained HbA1c reduction. So at the end of 28 weeks, so almost around 2.37% reduction in HbA1c was achieved with this fixed dose combination. So if you see the change in HbA1c from baseline to the week 28 of patients without dose escalation, without any dose escalation, it is they observed there was an achievement of 2.53% reduction in HbA1c at the end of 28 weeks without dose escalation. That is only with sitagliptin 50 mg, metformin 1000 mg, and glimepiride 1 mg. Twice daily dosage. So in these set of patients, when they have been followed up for a period of 28 weeks without dose escalation, they observed an HbA1c reduction of 2.53% reduction in HbA1c at the end of 28 weeks. And with respect to fasting blood glucose, and we can also see a sustained reduction in fasting blood glucose at 12, 16, 24, and 28 weeks. And at the end of 28 weeks, almost around 53.6 milligram per deciliter reduction in fasting blood glucose has been observed with this fixed dose combination. And with respect to postprandial blood glucose, also you can observe an sustained reduction at 12, 16, 24, and 28 weeks. And at the end of 28 weeks, we can observe around 78.6 milligram per deciliter reduction in postprandial blood glucose levels. So when you look into the number of proportion of patients those who have achieved a target glycemic control with an HbA1c of less than 7.7%, at even at 16 weeks is like 32.1% of people they have achieved HbA1c of less than 7%, and at 28 weeks almost 53% of people, that is more than half of the people involved in the study, they have achieved HbA1c of less than 7% with this fixed dose combination. So the efficacy conclusion at the end of the study, like fixed dose combination with sitagliptin, glimepiride, and metformin was significantly superior in comparison to co-administration of metformin and glimepiride in terms of HbA1c reduction at week 18. And also, not only HbA1c, we observed the fasting blood glucose and also postprandial also showed a very good change at the end of 16 and 28 weeks. So regarding the safety concerns, what are all the results was observed through this study with this FDC combination and the comparator is like when any side effects, any adverse events is like 13.2% with the test one product and 14.9% with the comparator product. Then with any serious adverse events is like 0 with the test one, and it is also 0 with the comparator product. And any treatment emergent adverse effects is like 13.2% with the test arm and 14.9% with the comparator arm. And drug-related treatment emergent adverse events is like 6.3% with the test arm and 7.9% with the comparator arm. So severe treatment emergent adverse events is nil with the test arm, and it is 0.5%. That is one event in the comparator arm. Otherwise, like serious treatment emergent adverse events or any like adverse events leading to drug interruption or drug discontinuation or dose reduction has not been observed in both arms. And also any adverse events leading to death has not been observed with both the arms. And this is a summary of treatment emergent adverse events with respect to both the test 1 and test 2. Test 1 means like with the glimepiride 1 mg dose, and test 2 is like with the glimepiride 2 mg dose. So any adverse events is only 4.4%, and any serious adverse events is 0, and any treatment emergence adverse events is only 4.4% again. And again, severe or serious adverse events or adverse events leading to drug discontinuation or dose reduction or leading to death is nil with this combination. So number of patients requiring hypoglycemia management through this study, what they observed through this study is in this double-blind phase, 4 patients had a total 7 hypoglycemia events, out of which 3 patients were from FDC of this FDC combination and 1 patient from the co-administration of metformin and glimepiride combination. In an open label phase, 1 more event of hypoglycemia is observed with FDC combination. All events were level 1 and asymptomatic. So these are all very minor hypoglycemic episodes. That is also asymptomatic hypoglycemic episodes. So there was no any significant difference between both the arms. So no patient required hypoglycemia management during the study period. So there's a difference between episodes of hypoglycemia between the test and comparator. There was not much difference, significant difference between both the arms. So the safety summary is all the treatment emergent adverse events were either of mild or moderate severity in test arm. So no serious adverse events were reported during the study period. 28 drug-related treatment emergent adverse events were reported in the study. Out of 28 related events, 12 events reported in the test and 16 events reported in the comparator arm. So the casualty assessment for all were probable or likely or possible. So not much of significance. So treatment emergent adverse events leading to drug withdrawal were not reported during the study. So hence this fixed dose combination is considered to be safe and well tolerated. So what they concluded at the end of this phase 3 study is like this FDC of sitagliptin, glimepiride, and metformin was superior in comparison to co-administration of metformin, hydrochloride, and glimepiride in terms of HbA1c reduction at the week 16, which was the primary endpoint. So the drugs were safe and well tolerated. So what is the synergy? How the mechanism of synergy between this sitagliptin, low-dose metformin, and low-dose glimepiride and the metformin is like glimepiride increases insulin secretion and the metformin increases insulin sensitivity. And so different pathophysiological disorder is addressed. And increase in cyclic AMP induced by incretin therapy potentiates potassium ATP channel so that independent insulinotropic action by glucose, so synergetically stimulating insulin secretion by this sitagliptin. And metformin potentiates DPP-4 inhibitor by increasing active GLP-1 levels. So there is a synergetic potentiation of incretin effect. So glimepiride increases glucagon levels. So when combining DPP-4 inhibitor with glimepiride, that decreases the glucagon levels. DPP-4 inhibitors decreases the glucagon levels. And metformin and sitagliptin decreases the hepatic glucose output. And sitagliptin increased homeostasis HOMA beta model when administered along with glimepiride, thereby reducing or decreasing the progressive beta cell function. And sitagliptin when added to low dose of glimepiride has shown to improve glycemic control with no increased risk of hypoglycemia. So in total, all these three drugs, they work together. They complement each other in terms of the mechanism of action, and also they shows significant synergism with respect to the insulin secretion and the glycemic control. So as an overall thing, there is a synergetic action which results in decrease in hyperglycemia. And also there is a risk, very much reduction in the risk of hypoglycemia, and also an advantage of preservation in beta cell function. So overall, this combination, looks very beneficial in terms of achieving glycemic control, and also at the same time with low risk of hypoglycemia. So now with the same case scenario, so the patient, the gentleman with an uncontrolled diabetes with metformin 500 mg and glimepiride 3 mg. So whether do we have an option now for maximizing this treatment and achieving a glycemic control? Yes, with this combination, I think it is possible. And what is what this fixed dose combination, how well it suits for this particular patient profile is that it helps to reduce the pill burden. For example, combining these three molecules in a single pill, so might will reduce the pill burden so that the adherence will be very good. And also it is an uncontrolled with the HbA1c of 8.4. It is an HbA1c of 8.4. It is the diabetes is uncontrolled in this particular patient. So, who previously is on a dual therapy with glimepiride and metformin. In those kind of patient, instead of regulating or increasing the dose of glimepiride, adding a sitagliptin might be very much beneficial for this kind of patient. And also patients with increased cardiovascular risk or CKD. So in those kind of patients also, getting the glycemia under control would be very much important. This molecule, it is highly likely to achieve the target in those kind of patients too. And reducing the dose of or the dose escalation of sulfonylurea, as I told before, it might help us in reducing or avoiding the episodes of hypoglycemia. So thereby, this combination is very good in that part also. And even patients, newly diagnosed patients, recently diagnosed patients, as we saw before with the the guidelines of American Society of Endocrinology, what they suggested is like when the patient have an HbA1c of more than 9%, like go on for a 2 or 3 combination drug should be initiated. So very well diagnosis if the HbA1c is more than 9%, newly diagnosed diabetic or recently diagnosed diabetic, and very well this fixed FDC combination of these three molecules would be very beneficial. Thank you. Any question?
Yes, sir. Thank you, sir. So, on behalf of the audience, there are a few questions that we have received, so I will ask them.
Yeah.
So the first question is that what, according to you, should be the time frame after which patients uncontrolled on dual therapy can be shifted to triple drug combination?
See, like for example, if your patient is on dual therapy, and if you're reassessing the patient after 2 or 3 months, and even after if the patient is following your advice about diet and exercise, and also the patient is very much adherent with his or her medication of this dual therapy, even after that, if the target is not achieved, then definitely, in 3 months' time, until you can very well go for a adjuvant therapy, add-on therapy. Yeah.
Okay, sir. And the second question is, do you think FDC with low dose glimepiride and DPP-4 inhibitor can potentially play a role in beta cell preservation?
Yes, definitely. Definitely, adding sitagliptin with glimepiride low dose, definitely it has an effect on preserving the beta cell dysfunction, and also progressive beta cell loss also has been believed to be reduced.
Okay, sir. And one last question, which is from my end. So I would like to ask you that in your clinical practice, what are the type of patients or on which parameters would you prefer this particular combination for?
See, generally, when if at all patient is like newly diagnosed with diabetes, for example, if his or her HbA1c level is like more than 9 or 10%, above anything above 9. So initially, I would like to go with a triple drug combination, unless otherwise if a patient is very old, like above 80 years old or something like that. So in otherwise, most of the patients, even young patients in the 40s, 50s, in the first go only, I would like to go with an aggressive mode of approach, like triple drug combination. So thereby, trying to achieve the glycemic control at the earliest, so that it is very important to prevent the micro and macrovascular complications related to diabetes. So any newly diagnosed patient with the HbA1c of more than 9%, or patients who are all very much uncontrolled with the dual drug therapies. And patient, who are all very much adherent to their diet and exercise and with some monotherapy. And still, if their SBONC is like with monotherapy, if it is more than 9, instead of, escalating them to a dual drug therapy, I will directly go into a triple drug combination so that, it might be easy to achieve the target glycemic target earlier than, in between going for a dual therapy and again observing for some point of time and again, escalating the third. So if you feel that the patient might not get controlled with this dual therapy after escalating from the monotherapy, directly, I will go with the triple drug combination.
Okay, sir. So, by this, we have come to the end of the presentation, and we've also come to the end of the question and answer round. So, on behalf of Arians and Pharma, I would like to thank you for your, first of all, your time at at this time of the hour, and also I would like to thank you for this insightful presentation from your end, which will help all of us to understand more about the usage and the combination and the various benefits of this combination. And I would also like to thank all the participating doctors for your patient listening and for giving us the time at this time of the day. So with this, we can end the session. Thank you everyone for joining.
Thank you so much.
Thank you, sir.
Thank you. Yeah.